So iron chelation therapy is a treatment modality that we often use in patients with lower risk MDS because MDS patients often have anemia. They need a lot of transfusions, iron buildup in their bodies, and that leads to problems in the end organs, including the liver, heart, and has been associated with worse survival when you are heavily transfusion dependent. While we have therapies to help the anemia, many patients end up needing continuous transfusions, and those patients would be generally recommended to start iron chelation therapy. So the NCCN guidelines recommend treating patients when they need more than 20 to 30 units of blood, or when their ferritin level is more than 2,500. So the standard options that are currently available include deferoxamine, which is an infusion given, basically it has to be given over 8 to 12 hours every night, 5 to 7 days a week, which is very difficult for older patients to tolerate, and the deferoxamine, which is oral, but both of those drugs cannot be used in patients who have renal impairment, which is quite common in patients with MDS because they are older, they have comorbidities. Both drugs can cause GI adverse events, so we generally need more options. Now there's a drug called Deferiprone, which is approved for thalassemia-related transfusion dependence as well as sickle cell disease, but there has been concern about it induces neutropenia or granulocytosis in some of those trials. Around 1 to 2% of patients have developed that, and because of that, those patients with MDS have been excluded. There's actually a warning on the FDA label regarding the use of MDS. So to try to answer the question, since doing randomized clinical trials is very challenging with iron chelation therapy, we looked at the question using real-life data, whether Deferiprone would induce severe or prohibitive neutropenia in patients with MDS, and we used the US Safety Registry, which was established after the FDA approval for the drug in the US in 2011. That had 115 patients, as well as a compassionate use program that enrolled 15 patients. And this is probably the largest data set of Deferiprone used in patients with MDS. And we observed that the rate of neutropenia basically was around 3%. So it's not much higher than what we typically expect in this patient population. The deaths that were reported on both of those databases generally were not related to severe infections. So I think given that we don't have randomized clinical trials, this is probably the best we can do in terms of having evidence about the incidence of neutropenia or severe neutropenia in relation to MDS patients using this drug. However, we have to know the limitations that this was registry-based analysis. There was no lab collected on the study. The reporting was voluntary, and it was done through a central pharmacy. So I think ideally there should be additional analysis to look into the safety, but big picture, we need better drugs for iron chelation therapy for our patients with MDS.